on.
Perfect. Thank you. All right. Yeah, no, I appreciate the doing this. So this is a slightly different version of a talk I gave about a year ago on more the general approach to the borderline aorta. And I really wanted to introduce this concept of Titan SVS, and I'll get into all the details very shortly. But it's a word you're going to be hearing about a lot, and it's an exciting new initiative led by a small group of Canadian aortic surgeons, which has a greater international reach in terms of aortic research. And by virtue of our strong aortic program, we've been asked to be part of this aortic research consortium that's called Titan. And specifically Titan SVS, Titan itself is an acronym for treatment in thoracic aortic aneurysms. So this is really research relegated to the ascending aorta at this time. And the SVS in Titan SVS looks at surgery versus surveillance. And like I said, and I'll come back to this point, but I just want to keep you aware, SVS is one arm of the Titan Aortic Research Consortium. There's in addition to SVS, there's Titan Commence, Titan Head Start, which I'll give brief definitions of later, and a Titan Biobank, Titan Core Lab. So it's really kind of an interesting way of doing research, of kind of consolidating resources and efforts across the country to better affect research. So Titan SVS, and you're going to be hearing a lot about this and around the hospital, and I refer to it in my referral letters more and more often. So it has implications for referring physicians, GPs, and cardiologists. So you will be hearing the word Titan a lot, and specifically as it pertains to SVS. And it is a randomized controlled trial we are involved in, and I'll get into the details of that. But we're speaking about the borderline aorta. So if you have patients who have what we consider, by our definition of borderline aorta, an ascending aortic aneurysm between 5 and 5.4. As it stands right now, I'm not including those that are over 5.5, the vast majority of which we do operate on, and there's few we don't operate on that are over 5.5, and there's very few which we would operate on under 5. Except, so really, I want you to just remember this: it's the borderline aorta. This is really the gray zone of aortic intervention for the ascending aorta. It's a question that's been perplexing aortic surgeons for a long, long time. And there's a lot of patients that are in this category and group. And it's a question that really, really deserves an answer of how best to manage these patients with this challenging problem. And the Titan SVS is our attempt to answer that question. So again, Titan SVS refers to treatment in thoracic aortic aneurysm, surgery versus surveillance. So this is really it's a landmark trial. Nothing like this has ever been done for the ascending aorta, and it's truly randomizing patients with a 5 to 5.4 aorta in either surgery versus surveillance. And the primary outcome here is impact of early surgery versus surveillance, and the all-cause mortality is really the main primary outcome. And we have a number of secondary outcomes we're looking at, including incidence of acute aortic syndrome at follow-up, 30-day mortality, incidence of elective ascending aortic surgery and morbidity and mortality associated with that, stroke in both groups. And another big one is really number 6 here is quality of life assessment in both groups. So just to go through the sort of screening process and the tool we have, and not to get too complicated, but really the essence is you have an individual with an aorta that's 5 to 5.4, and does not and fulfills the eligibility criteria. And I'll go through the eligibility criteria right now. So under 5 or under 4.9, they are not a Titan candidate, but these are still important people to capture as because if they do cross the 5 centimeter threshold, they will potentially become a Titan candidate. Those that are over 5.4, 5.5 are generally considered surgical candidates anyways. And those that are over 5.5 that are considered unfit for surgery for a variety of reasons will go into a registry arm. So those that do not fit the surgical criteria, but are over 5, we do have a registry arm, which we follow for a rate of growth and a variety of other variables. So this is the form that we use, and I'll go through this because it's quite important. The eligibility criteria and exclusion criteria are quite strict. So obviously they have to have an aneurysm between 5 and 5.4, as measured by a recent CT within 6 months. So exclusion criteria are as follows. 1, those who refuse to be randomized. Those with symptoms are excluded. Those unable to provide informed consent, unable to provide follow-up, any of those with previous cardiac surgery, or who have another primary indication for cardiac surgery are excluded. A fast rate of expansion greater than 5 millimeters per year. Primary arch aneurysms with secondary ascending aortic aneurysms are included. Those with connective tissue disorders are excluded. Those with familial aortopathy, so those with a significant family history of acute aortic syndrome, aortic related death are excluded. And those with a significant other medical condition, whether it be lung disease, liver disease, severe renal kidney disease, are excluded as well. So there's a lot of exclusion criteria, and it's, as you can see, I'll get to this point later, that it tends to be a dwindling pool of potential applicants that are eligible for the study, which makes the trial challenging. So this is it's an international study primarily focusing on North American sites. And we've been one of the early centers asked to participate in this, and it includes a lot of the major aortic centers in North America. This study started in 2018, and recruitment continues and is ongoing. So I'll show you a couple slides here from that's recruitment and enrollment as of July 1st, and I have a more updated slide here from September of 2021, and this is a note and laudatory note to our research team here, including Carol and Laura, have done a great job in quarterbacking the complex issues around getting this study off the ground. And we've been lauded as one of the highest recruiters. So we're in the top 3 here, and I think we're up to 10 now in the randomized group, but we're in the top 3 here of recruitment. So they've been really impressed with our research group and our organization and ability to recruit these very, very difficult patients. So again, I just want to give a little bit of background and really make clear why this trial is needed for several reasons. One is the guidelines are terrible, and that's mainly because there's such a lack of quality data, which is what we're trying to fix here. And it's an interesting clinical conundrum whereby there's true clinical equipoise in how to manage these people. And I'll show you some survey studies that this group has done as a preamble to this trial. And we all know the major problem that thoracic aortic disease presents. It's The second point is not lost on us, that it remains asymptomatic until a catastrophic event occurs, and the morbidity and mortality for patients who undergo treatment at this acute stage is exceedingly high. So the need for identification, surveillance, and timely treatment of patients is really imperative, and something we're lacking greatly. We know how this is the surgical treatment of it, and the risks and benefits we always try and weigh. And certainly, it's a big operation. It's major cardiac surgery with its attendant mortality and morbidity risks, even in the healthiest of people. Combined with the risks and benefits of the natural history of the disease, that being risk of dissection and rupture, and really our inability to predict is extremely poor in who will progress down this path of dissection and rupture. The last dissection I did a week and a half ago at presentation, his aorta was just under 5 centimeters, so not someone who you would even consider operating on if you saw electively. So again, our ability to predict is quite poor. But that being said, size matters, and it's very difficult to know what the right size is, because there's such a great variability in size in all of us, based on body surface area, gender, and a whole host of other factors. So there's really no normal aortic size per se, and that's the essence of it. I do often use these nomograms based on height and aortic size and relative risk of rupture as time goes on. So we do try and index these and that's sort of the most sophisticated we get with measuring these. But I also want to emphasize the point, as I said before, the last dissection I did was well under 5, and a lot of these acute aortic syndromes, catastrophic events, occur at less than 5.5. I'll just go quickly. That's the essence of these slides, but this is a summary. Various data demonstrate that 15 to 30% of patients who present with an acute dissection present before that threshold for prophylactic repair is reached. And we do have some guidelines, consensus statements from Canada and the US and the European guidelines, which are poor at best, and very generalized. And the summary of those is that, we all know ascending aorta greater than 5.5. We operate on 5 to 5.4. We generally try to include patient risk factors and try and develop sort of a more nuanced method of making a decision. But really, it's surgeon specific, surgeon practice specific, and it's not accurate, and it's flawed at best. So the level, as I said, the level of scientific evidence is poor. There's no true randomized data for the thoracic aorta, with small retrospective studies and consensus opinions only, and which leaves lots of room for flexible interpretation. And really, in today's day and age, that's not how we tend to practice medicine, and a move towards evidence-based management of these patients is what's really needed. This meta-analysis demonstrated that the rate of growth is slow, risk of dissection rupture may be lower than previously understood, and the outcome and conclusion was a randomized controlled trial would be required to understand the benefit of surgical intervention versus surveillance. And really, we have one great example in the aorta, just downstream a little bit in the abdominal aorta. This study has been done with abdominal aortic aneurysms, a randomized trial comparing 55 and less with surgery versus surveillance. And clearly, abdominal aortic aneurysm smaller than 55, the risk of early surgery outweighs the risk of rupture during surveillance. So this is very strong evidence-based data that we have for the abdominal aorta. And our aortic leaders we say that there's no reason we can't get this data for the ascending aorta. So this is the essence of what Titan SVS is trying to to answer for us. This is as a sort of a preamble to Titan SVS. The core group of aortic surgeons did this survey of various practitioners, including surgeons, vascular surgeons, and cardiologists. I find this interesting, and I use this in discussing this trial with patients. The question being, I'll read it verbatim: recognizing each patient is different, what is your usual size threshold for recommending surgical intervention? This is an asymptomatic adult incidental finding, and the patient is otherwise a good surgical candidate, no valvular disease, no genetic aortopathy. And this is the clinical equipoise I discussed earlier. Truly half and half, 50% recommend 5, 50% recommend 5.5, essentially. And really, if you look at the guidelines such as they are, over 50% of respondents would offer surgery at a size threshold smaller than current guideline recommendations. So really, a wide variety of responses with true clinical equipoise, and a question, this the equality of this should not exist in this type of problem. And which one of the following criteria would cause you most to consider altering your usual threshold? And 80% of respondents would alter their surgical threshold based on a certain patient factor, whether it be gender, BSA, bicuspidity of aortic valve, age. And so again, just to review quickly, this is the question that Titan is trying to answer. And these are the sort of a complex slide, sorry, but the endpoints and timeline of Titan, and including measurements and variables that we're including quality of life. And we're trying to get upwards of data into 2025. Our ideal goal is 3-year follow-up. This includes quality of life data, stroke data, growth rate data, and imaging analysis of those in their surveillance group. So quite a large amount of data. It's a complex trial with complex design issues. Again, the optimal primary endpoint needs to be specific, clinically important, unambiguous, and measurable. Sample size is a challenge. Currently, our goal is to reach several hundred in the randomized control trial. And again, I'd just like to discuss some of the challenges associated with randomizing these trials, and probably a major reason this trial hasn't been done to date, and has taken a lot of organization and a lot of people coming together with similar thoughts on this to try and get enough patients to be able to randomize. Obviously we have a great degree of sources of surgical referrals, various aortic clinics and primary care and cardiologists and internists sending patients in with patients with aortas between 5 and 5.4. And assuming they fulfill the exclusion criteria and they do meet the eligibility criteria as they are, there's a certain amount of surgeon bias and surgeon practice bias that enters into the equation. Based, we all think of these patients slightly differently, whether they're young patients, obese patients, whether or not they have valvular disease. So I've learned a great deal in discussing this with these patients, and I've really focused on sort of the psychology of aneurysms. And when I started this trial, I thought, yeah, it would be quite easy. We can, and start enrolling these patients. But when you really get into the nitty-gritty of discussing these issues with these patients, you really understand the effect this has on the psychology of the patients. And it really takes about an hour of discussion with each of these patients with me to try and have them understand what we're trying to do with this trial. And some patients have an issue with it. Some patients say, no, I want to wait till 5.5. and some are on the other end of the spectrum, say, yeah, this is great research, and I want to be part of this landmark trial, and are very interested in being part of it. But it really made me appreciate the great range and spectrum uh, of of how these patients think of these aneurysms, and it made me respect it a great deal more. So um, I'll just continue to wrap things up here. COVID obviously has been a significant impediment to recruitment, and we've changed a lot to virtual clinics, and research was suspended for a little bit. But anyways, hopefully those obstacles have been overcome. Um, so again, I just want to underline the importance of the Titan program on a grand scheme. Um, Core Lab associated with the Titan Aortic Research Consortium, the Biobank. And as I said, Titan SVS is but one arm on the flywheel of aortic research being done. And it's being led by a small group of Canadian aortic surgeons out of Ottawa and Calgary. And we are also going to be part of Head Start soon, which is looking at type A dissection and arch management in type A dissection. Anyways, I'll wrap it up there. I hope that's clear. And when people hear the word Titan, they have a little bit of a better understanding of what's happening with these patients. But if you have any questions or issues, furthermore, please don't hesitate to touch base with me or chat to me about these patients. Thank you.
Thank you very much, Zlatko. If you would stop sharing the screen so we get everybody on screen. I mean, I think this illustrates, you know, a very important aspect of which you have sort of differences in terms of what clinicians do, guidelines published, and evidence, and how you bring all of those things together. And clearly in the aortic world, there's obviously an area here that is pretty gray. I mean, I find it striking to me that a survey would actually show that amount of I mean, it's pretty striking, even the bicuspid nature of things. As you know, that's been a swinging pendulum. It almost makes me worry a little bit that maybe we're not educating ourselves as much as we should. Our review of the current literature or current evidence may not be as up to date as it should, you know. Anyways, just your comments along those lines. I mean, this is critical to me.
Absolutely. I mean, it always impresses me. It's such a major problem, and we don't have a clear answer for it. And even, I mean, I think we've done a reasonable job, and even including meta-analysis, recent meta-analyses. This group has really combed through the data in detail, and I think that survey is really an accurate assessment of what's happening clinically today. And I use that when discussing with patients. And I truly say, you know, if you have a 5.3 aneurysm, I guarantee you, you know, if you ask 10 aortic surgeons, 6 would go one way and 4 would go the other way. And there really is no right answer here. And I tell them, and then for me to include them psychologically myself in the trial, I have to be purely comfortable with going with either way.
Yes.
Watching them or operating on them. So it always impresses me. It's such an important clinical problem that we don't have an answer for, and there's no reason we can't follow the model of the abdominal aortic aneurysm, and we have a clear answer for that. Everyone knows 5.5 for the evidence, and it's clear randomized controlled data. So I think that's a great model for us to follow.
Now, I wonder if you
are there any advanced imaging studies being done on these patients?
There's a lot, there's advanced CT studies. This is all in trial data though. And there's a lot of looking at sort of stress and strain of the aorta and modeling of the aorta, and using that as sort of a guideline to try and predict which ones will progress to an acute aortic syndrome. These are all in early stages, and there's really no other imaging we have at this stage that's practical, that's usable on a daily level.
Yeah, I would, if you were to comment as Zlatko on, you know, there's quite a few cardiologists on the call, and echo would be the most common place where they would potentially see an early sign or an early finding. What's your sort of gold standard to go from there if you're concerned about an aortic size?
Yeah, I think echo is a great screening tool for sure for many. But CT does continue to be the gold standard for measurement. I think if you're starting to see aorta is a 45 or more on echo, I think you have to refer them on for CT. I think if they're still in the low 4s, I think it's reasonable to consider to have them screened with echo under 4.5. But as they're approaching 4.5 by echo, I think you're obligated to have them to proceed to CT or refer them at that point, I think is reasonable as well.
Yeah, and if you would also comment on CT and the reading of CT, I mean, there's there's quite a bit of variability
Yeah,
from that
so
point.
I think I saw a couple of people yesterday. I think, you know, the measurements were just wrong, you know, and it meant the difference between no surgery and surgery. I think 2 out of my 10 patients in clinic yesterday, that was the criteria. So, I mean, I just have to, I measure them all myself. So you cannot rely on the measurements that are in the CT report, period. Sorry.
There's no radiologist on the call. I don't know.
Zlatko, in the aortic clinic, you know, before this trial started enrolling, do you have a sense of how many of these people you've been following with this kind of borderline, you know, 5 to 5.4 centimeter ascending? You know, what kind of volume or proportion of people that you follow fit into this category and you know, would be potentially eligible for this trial?
Yeah, that's a good question. You know, our aortic clinic sort of is in the several hundreds now, and with a variety of patient sort of pathologies, but it's not an insignificant number. I don't have a number off the top of my head, but we're trying. I'm trying to go back as well and kind of find these people who would be eligible and go back retrospectively in the list. But there's a large number, Chris. Yeah.
All right. If there's no further question, I thank everybody. Thank you, Zlatko, for the great presentation, and encourage everyone, if you have questions, please refer questions to Dr. Pozeg or to any of our team that can help you sort out how to surveil these patients and follow them over time. Thank you very much. And this is the end of rounds. Have a good day, everybody.
Thank you.
Bye-bye.